We have more than 40 different support groups that meet here every week. We have lots of educational outreach, both for community members and for professionals. Some of the activities in the evenings are for people like yourselves who are trying to earn some extra CEUs. We also do mental health coaching. We have telepsych services, and we do research. And I have a very specific niche. Somebody just asked me what BCC meant, Board Certified Chaplain. So my own background is healthcare chaplaincy, primarily in the ICU, and that's how I came to get involved with healthcare ethics. I had lots of families that didn't know what to do. You know, they are, and I'll talk a little bit more about, as the evening goes on, about the frustration and the technology that's happened in medicine. And so we have to be real cognizant of that. So I do essentially the things that the Hope and Healing Center does, but in the aging and ethics space. So as you can imagine, our population is aging, more people are getting older, all the problems that arise with dementia and caregiving, and how do I handle all of this stuff with the healthcare empire and insurance. So I offer a regular series here in the spring and fall on Aging with Grace, which covers the healthcare, legal, living, and financial aspects of aging. I also teach a 6-week class for caregivers of people with dementia. And I do classes like this one, both here and around the community, both for professionals and community members. And I do research. I have a particular interest in physician-patient communications. So, and also end-of-life planning. All of those, you know, pull on all of my experiences in the hospital and here. So I've been here, I'm in my 4th year here at the Hope and Healing Center, so I'm really blessed to be here. So tonight, I'm going to talk a little bit about the healthcare ethics space, what's going on there, and how do professionals in the healthcare arena approach it. And there are lots of things, lots of problems that come up, lots of issues that arise. I assume most of you are social workers or counselors. Any other fields represented? So that you've seen, I'm sure you've seen some of these issues arise. And we're going to talk, and I encourage you to bring in your own experiences, because I'm not a monolith. I don't know everything there is to know. I don't have anything to disclose. I work for the Hope and Healing Center. I don't sell any products. I don't have any commercial interests. So tonight we're going to talk first of all about the environment of care. What has happened in medicine, or what is happening as we go along? I'm going to talk a little bit about some of the legal precedents that have given rise to some of the things we see in healthcare now, particularly in terms of patient self-determination. There was a time where patients did what the doctor said, no questions asked. And then some cases arose where that wasn't really such a good idea. And so the legal precedent now is that anybody can refuse any treatment for whatever reason they want. And they can ask for alternative treatments for any reason they want. We're going to talk a little bit about the core healthcare ethical principles that we work with in medicine on a day-to-day basis. And we're also going to I'll go through some of the questions, and I'm not smart. I wish I'd made up all of these questions, but they've arisen from 3 fairly prolific thinkers in the whole space of ethics, Bill Winslade, Albert Johnson, and Sigler. I don't remember his first name off the top of my head. But they've come up with some really good questions that become core that we can talk with families when issues arise. And finally, the important part at the end of the day is to help patients and families articulate what's important to them. And there are different ways of doing that. And I'm going to talk about it both in terms from the patient side, healthcare directives and that sort of thing, but also from the professional side in how can we talk with families when they're uncertain about making decisions. So, and that reminds me, there's one other service we offer here. We also have a clinical ethics consultation service for people who are not in the hospital setting who have care plan issues. So we've recruited a group of doctors and nurses, spiritual care providers, and other folks who, from the big committee, will recruit to help a family person, an individual or a family with specific issues. So, when we talk about our health care, we have to set goals. And I'm going to talk a little bit about how we do that and what's important. What's the role of ethics and all that, both legally and principally, and then in decision making. Because at the end of the day, we have to bring all of those things together to make decisions. And the challenge is that from a user perspective, most people don't know much about how the healthcare system works or how medicine works or how specific treatments work. We have openings from programs on television. I don't know about y'all, one of my guilty pleasures is watching some of the medical shows on television, and then I sit there and I go, no, that's not right, and that's not right, and I've never seen that happen. But that's what people see, right? So that's what they think is going to happen. So it's important to help them cross that divide. So what's the environment of care now? Well, clearly, medicine's ability to prolong life has expanded exponentially in the last 20, 30 years. That has happened in part because of medical specialization. And as with everything in medicine, it's a double-edged sword, right? We have medical specialists who can focus on the heart or the liver or the kidney or the lungs or the brain, but then they don't talk about other stuff that's in the body. And one of the sources of frustration I used to see in the ICU was the parade of specialists would come through and the lung doctor would say, well, your family member is breathing a little better today. And the kidney doctor would come through and say, I'm really sorry, but their kidneys are failing. And you would get 6 different responses for 6 different organ systems. And it's frustrating, right? How do you deal with all of this? The other thing is surgeries and anesthesiology. If you go back 100 years, some surgeons were barbers. That's what they did, and they give somebody something, to bite on, the proverbial bullet to bite on. But there were limits to the surgeries that could be done because the patient was awake. So what anesthesia has done is given us an ability to have more lengthy, complex surgeries, and the patient sleeps through it. Intensive care units, that thing that I mentioned, the ability to have an environment where a patient has one nurse to one patient or 2 patients to one nurse instead of 6 or 8 or 10 patients to one nurse has really changed our ability to serve people who are really, really sick and need additional attention. You know, all of the stuff that we have now, the dialysis machines and the ultra slow dialysis and the heart-lung assists, all of those things need a lot of attention. And without the ICU, you wouldn't have this. The other thing that has changed is that organ failure may not equal death. If you go back prior to the 1950s, if somebody's kidneys failed, they died. And in fact, a little factoid for you, the earliest application of ethics, of healthcare ethics, was in the decision for who would get dialysis, because this was a life-saving technology. It was also the first time the government stepped in and said, because this is such a dramatic technology that can save so many lives, we want to make sure that everybody who needs it gets it. And the first Medicaid program was born. Heart failure, it no longer has the same implications for someone. They may have to take medicines, they may have to have a special diet, they may have to have surgery, but in general, heart failure no longer means you die now. There's lots of life-prolonging treatments that can be had. Artificial nutrition and hydration. And we could do a whole night on ANH and the implications of it. But when you look at the ability to keep the body's chemistry nutritionally balanced, that's a major change. For people who are unconscious, that may be on ventilators for a period of time, they will need artificial nutrition and hydration. I have a friend and former neighbor who was treated for esophageal cancer, and he had to be on artificial nutrition and hydration for a couple of months after he was operated on to give everything a chance to heal. And there are people who are then in a vegetative state that are kept going with artificial nutrition and hydration. And that has some implications with some of the legal precedents, which I'll talk about in a minute. So all this has raised new ethical questions. We don't always know, and it isn't always clear how to address this stuff. So what we're going to do tonight is talk about some of those parameters. Because at the end of the day, for everybody in this room, the answers may be different. Because we come from different cultural backgrounds, we come from different religious thoughts, and that affects the decisions that we make. So when we talk about the goals of care, the meta question in all this is, what's important to me in my health care? Can I be cured? Do I want my life to be prolonged? Under what conditions do I want it to be prolonged? Do I want my function to be better? Do I want my wrinkles to go away? What do I want to do, and to what degree can I and will I and do I want to stay in control? And so all of these goals of care are going to be different for every person, and different goals may apply at different times. So we have to think about what is important to us. What are my life goals as well then? Possible language that you may hear people use. I want to have the best life possible until the day that I die. I want to live meaningfully. That's something that's really important to me, and I have very specific terms that I've communicated to my family on what's important to me. I want to remain independent. You know, my own dad, who lived into his late 80s, had heart problems, and he went through a period where he was pretty sick and in and out of the hospital. Nobody ever told him he would never live alone again, and nobody ever told him he would never drive again. And both of these things were really important to him. And he came to terms with them. But somewhere along the line, perhaps somebody should have said something to him because they knew it was important. He had articulated that. And I think probably one of the hardest days of his life was the day he had to sell his car, even though he hadn't driven it in over a year. Where do you want to die? You know, statistically, 80% of people say they want to die at home. That's what they say. But in real life, it's more like 80% die in other places, either a hospital or a nursing home or some sort of care facility. So we haven't managed as a society to come to terms with all of that and to make all of these different wishes match. So now we're going to segue into ethics. What are ethics? Pretty simple definition, right? Moral principles that govern a person's behavior or the conduct of an activity. There are all kinds of ethics. Business ethics, legal ethics, morals, healthcare ethics, social worker ethics. Everybody has some sort of ethics that they operate to. So in the legal world, and remember at the basis level, healthcare ethics are established by the law. And one of the challenges is when there's the ultimate disagreement, the court ends up being the place where everything gets arbitrated if it's really, really bad, but it's probably the worst place. Because the court doesn't care about your person and what's important to you. Quinlan, Karen Ann Quinlan had an episode where she lost consciousness for an extended period of time. They got her heart started again, and she was on a ventilator and a feeding tube. And after numerous years, her dad went to the hospital and said, "This is dumb. This is not my daughter anymore." And the hospital refused to disconnect her life equipment because they said they would be committing murder. So her dad took them to court. And the court agreed that based on his comments that, you know, this was not what she would consider living, they actually instructed the hospital to disconnect the ventilator. The hospital was maliciously obedient and slow-weaned her, which meant they very, very gradually got her off the ventilator. The catch was nothing was said about the feeding tube. So the combination of the feeding tube and the slow wean on the ventilator resulted in her living for another 10 years. And think about her poor parents and all this. So that gave birth to the state of California, which is in the forefront in a lot of this stuff. They passed the California Natural Death Act. And it started setting the stage for people being able to articulate ahead of their demise what their wishes would be under certain circumstances. Then that proceeded along, that whole movement proceeded along. And then Nancy Beth Cruz also wound up through a medical emergency in a vegetative state. And her dad went to sued through the state of Missouri And they basically said, nuh-uh, we're not going to do anything. There's not enough proof that what you say about your daughter's wishes is true. Well, the appeals court threw it back to Missouri and said, no, you can't just say that. You have to do more work to figure out what was important to her. And so eventually they did rule that support could be disconnected, and everything was disconnected, and she died pretty quickly. So when you see the years here, 76 for Quinlan and the California Natural Death Act, and then 1990 and the Patient Self-Determination Act, that's not an accident. The Patient Self-Determination Act was then a federal law saying that people could determine their treatment choices, and they could articulate what they wanted. I put up Oregon because I get asked about it a lot. I'm not talking tonight about physician-assisted suicide. They're now, California, Colorado, DC, Hawaii, Montana, Maine, New Jersey, Vermont, and Washington allow physician assist, it's called physician aid in dying. And in that case, the physicians have to write the prescriptions, but they're not allowed to be there for the prescriptions to be administered. And there have been some fairly prominent cases. Probably the most recent one was Brittany Maynard, who moved to Washington so that she had glioblastoma, and she wanted to use it because she knew the end was not going to be pretty. She was already having seizures, and she didn't want her family to have to suffer, and she didn't want to suffer through a demise that was not going to be very pleasant. I could spend a whole hour or hour two, we could talk about physician aid in dying. I just want to put this on your radar as to note that the laws are changing. And it's sort of an interesting dynamic because it's very different from what's been done in Europe. So here are the principles. The two guys named Beecham and Childress, and then Johnson, Sigler, and Winslade took their 4 principles and tweaked them just a bit. So Beecham and Childress came up with autonomy, respect, autonomy, which then Johnson, Sigler, and Winslade changed into respect for persons, saying that the autonomy is kind of the idea that I can decide for me what's best for me at any time. Respect for persons is a little bit broader. Beneficence, we're going to do well by our patients. Non-maleficence, we're not going to hurt them. And the one that I would argue, or we could probably debate, that justice is the piece we're worst at, because we really do have a multi-tiered system in this country. When it comes to ethical decision-making, then Johnson, Sigler, and Winslade took these principles and turned them into medical indications, patient preferences, quality of life, and then the context of the disease process. And so they ask some questions when it comes to each of these areas that I'm going to go into here. The medical indications, the basic one, right? What's the patient's problem? What are the goals of the treatment? Remember we said earlier, all those goals, they're varied and they can depend by the disease process and by the patient's choices. Under what circumstances are treatments not indicated? In the healthcare world, in Texas and some other states, it's come into a big discussion about futility. At what point can the medical system say, we're not doing this patient any favors? What are the limits? What are the probabilities of success? That's an important question to ask. If you've got cancer and you've been through 2 or 3 rounds of chemo, and as the Hail Mary pass, your oncologist says, well, we can do this experimental protocol, what's that going to buy me? And what's it going to cost? It's an ugly question, but we have to ask that, right? And then, how can the patient benefit from treatments, and how can we avoid hurting them? So what are the patient preferences? Has the patient been told of what the benefits and risks are of every treatment option? And that's the part in the healthcare system that we still have the hardest part with. There is still a paternalistic view. The doctor will say, you have such and so, and this is what we're going to do. And what are the problems with that? Well, I talk to a lot of older people for whom the cost of meds is prohibitive. And so one of my jobs is to train people to say, that medicine costs more than my food budget for the month. I don't have that kind of money. What are my options? When I worked in the hospital, the social worker used to carry around the list of inexpensive generic meds. And when the patient said, I can't afford this diabetes drug, they'd say, well, talk to your doctor about this one. It's a challenge, right? The efficacy may not be quite the same, but it's better than not eating. And we have to think about that. Is the patient mentally capable of making a decision? And that becomes really important because when we talk about medical powers of attorney and default decision makers and stuff like that, we sometimes get to a situation where the person is not making decisions for themselves. They have to rely on their family or friends to do that. So what people rely on in the absence of a written document is what has the patient said. And there have been several legal instances where the question arose, what did the patient say and how did they approach it? So then who's the appropriate surrogate? We're going to talk about surrogacy in a minute. And is the patient unwilling or unable to cooperate with medical treatment? And why is that? If a person has dementia, they can't make decisions. They can't even remember to take pills. I've heard some horror stories about people saying, well, they lined everything up in those little pill counter things that said, take these in the morning and these in the afternoon. And the person would get confused and either not take anything or take everything. So we have to think about that. Quality of life. Remember I said, what's important to the person? I really think that that's the crux of everything. What are the prospects for return to normal life, and what are the expected deficits? I'll pick on my dad again. He was never told he wasn't going to live alone and he wasn't going to drive. And for some people, that would be a job stopper. He learned to adjust happily. What are the grounds for judging the quality of life if the patient can't respond? So I've talked to people whose family members are not unconscious, but they're not really aware of what's going on. What are the provider's biases? Doctors and nurses have their own biases. Some doctors want to keep treating for whatever reason until the cows come home. They don't take into, well, I'm not going to do that. I'm going to keep treating you. I'm going to keep giving you medicines, and I'm not going to think about all this other stuff. What are the ethical issues? We do have issues with when do you do a feeding tube? Standard of care for a person in the final stages of Alzheimer's used to be you put in a feeding tube, no questions asked, no matter how out of it the person was. Except, even when a person is in advanced dementia, they fiddle with things. And so they were pulling, the experience was that the people were pulling the feeding tubes out or fiddling with them so they got infected, which caused a whole nother series of problems, because how do you explain to someone with the mentation of a 1-year-old what's going on with their body? You can't mess with that. You can't tell people like that what to do. So then are there questions about the possible treatment plans? So if the neurologist and the person treating someone with advanced dementia is doing their job, they will sit down and talk to the family about what has been important with the person. And trust me when I say this, there are things worse than death. So are there any interests that might create conflicts? The standard one in the healthcare annals is a Jehovah's Witness with a blood transfusion. You never, that's prohibited. Are there any other parties who have interests? Clearly the family members have an interest because they have caregiving responsibilities. What are the limits on patient confidentiality? Fortunately, that doesn't arise too often, but every once in a while it rears its ugly head. Don't like to talk about money when it comes to healthcare, but it is a consideration. Particularly, I had a colleague in the hospital who was an ICU nurse, and her husband had some form of cancer. And he was coming to the end where conventional treatments were not working, and he was a patient at MD Anderson, and they wanted to do a treatment that was going to cost, that involved an injection that cost $25,000 or $30,000 every other week, and insurance didn't pay for it. And her comment was, "We don't have that kind of money." Sad but true, right? That's the real world we live in. So what she ended up doing, and was the best choice for her and her husband, is they switched oncologists who would do with more conventional treatments that would extend his life, but not indefinite, to the same degree that this new and better medicine was expected to. Are there any funny institutional affiliations? We read about those, right? Researchers it's getting harder and harder to get research dollars. And so you have to ask the question of your docs, if they're researchers also, what are the conflicts, the potential conflicts here? So how can we help? All this sounds like a big conundrum, and it's a big mess. How can we help? The first thing is to ask people about their goals. What's important to you? Till my, the last breath I take, I encourage families to talk to each other. Talk about what's important. We're really bad at that as a culture. We don't want to talk, but we are all going to die. I hate to give you the bad news. I was reading today about Miriam, Moses' sister, and she was brought back. And then a couple of chapters later, lo and behold, she still died. She was brought back, but she did die. Oh, and then finally to promote the documentation. So I'm going to do a quick spiel here on advanced directives. How many of you have done advanced directives? Most of you, good. Everybody should have advanced directives. I don't care if you're 18 or 80, because that is the way that you begin to articulate some of the things that are important to you. Every one of us, if I wanted to do an exercise in self-disclosure, I could go around the room and say, what's important to you? What's important to you? Mm-hmm.
That my son is successful.
Okay, that her son is successful. What's important to you? That you stay active as long as you can. You know, we're living longer. One of the reasons that Social Security was set up the way it was, that retirement was at 65, was because people were basically living into their late 60s, maybe early 70s. Now the average life expectancy is over 80. I have a number of friends who have now been retired longer than they worked. And that's what longevity has done for us. And I'm not saying it's a bad thing, but it's a real thing. So we all have things we like to do. We have control that we like to have. If people like me, and I still am a recovering type A, I like to control everything, right? I have goals. I have things I hope for. That your son's successful. That's something. I hope the same thing for my children. I have 2 adult children, and they've just launched their careers, and aside from wanting to keep them off my payroll, I want them to be successful human beings in their own right. So what advanced directives do, and what the Advanced Directives Act allows us to do, is to begin to articulate some of these things as far as our health care is concerned. Now, what the advanced directives don't cover are the life goals kinds of things, which is why you've got to talk about your health care in the context of your life goals. So if you want to be active and you're in a vegetative state, you won't be able to be very active. So, in the state of Texas, there are 4 directives. There's the medical power of attorney, where you indicate whether who you want to make decisions for you, if and only if you are not able to make decisions for yourself. The important thing to remember is, as long as you're still mentis compos and able to talk, anything you want done or not done is up to you. And this is something that I have had family members and patients who didn't understand that differentiation. So if you're unconscious and not able to speak for yourself, then your medical power of attorney speaks for you. In the state of Texas, there's an automatic default. And the automatic default is spouse, adult children, parents, siblings, and then anybody else who's willing to make a decision, any other family member. In the medical power of attorney, you can override that. So if your spouse is incapacitated for whatever reason, or you have a spouse that's just not able to make good decisions, or your children are adults, but they just don't want to, oh, Mom, I don't want to talk about that, then you can name somebody. And as I always tell people, it's important to identify someone who'll do what you'd want and not what they want. In the state of Texas, all you need is 2 witnesses. It does not have to be notarized. It can be notarized, and if you've done a will with a lawyer, the chances are they've done a medical power of attorney for you with a notary, and that's fine. But the thing to remember here is if you've got a client or a patient or a family member who wants to complete this documentation, all you have to do is print it off the internet, and I give you the link at the end of the presentation, and you can use visitors or neighbors or whoever to sign it. The directive to physicians and family or surrogates, which is also called the living will, commonly called a living will, gives you the ability to indicate whether you would or would not want heroic measures if you were unconscious and have an irreversible or terminal disease. The rub is in the definitions. I have had doctors tell me they don't even know what heroic measures means. And I can guarantee you from some focus groups I did last year that normal people don't know that either. In one group, some folks said, well, maybe it was when a policeman or a fireman runs into a burning building to rescue somebody. That's heroic, but it's not a medical heroic measure. I'll talk a little bit about that in a minute. And an irreversible illness is one that can be treated but not cured. So the example I use is if someone has Huntington's disease or Lou Gehrig's disease or has had a massive stroke. Those kinds of conditions can be treated, but they can't be cured. A terminal condition is one where the doctors have said that you have less than 6 months to live. So the advanced stage cancer would be, advanced stage heart disease, those kinds of conditions. Again, 2 witnesses, can be notarized, doesn't have to be, pretty straightforward. Declaration for mental health treatment. It's interesting that I work at the Hope and Healing Center where a lot of our clients have serious mental health illness or serious mental health issues. I've never had anybody ask me to fill this out, but it gives you an opportunity to indicate in advance whether you would want certain treatments. Again, witnesses, no notary, copies are acceptable. The last one for a very elderly person or somebody who is really, really sick is important. By law, if your heart stops, EMS is required to try to restart it. So what an out-of-hospital DNR does is it gives you ability to say, if my heart stops, I'm 80 years old, I know they're gonna break every rib in my body and they're not gonna help me, let me go. And for most people who go on hospice, the family will ask for an or the hospice company will ask for an out-of-hospital DNR. Makes sense, right? Have any of you ever seen CPR in process? What was it like? It was intense. Did they bring the person back?
Yes.
They did bring them back. Are they okay now?
No, they later passed on, but
It was a temporary. Here's the other interesting statistic. On television, somebody actually sat down and counted. More than 80% of people recovering go home fine. In reality, even if you're in fundamentally good health, the likelihood of surviving CPR is about 15%. And if you're really sick with something or very old or deconditioned, it goes down from there. So I watched them in the hospital do CPR on this 80-year-old lady who was this big around, and you could hear the bones crunch. Not a pleasant experience. So if you have any family members who are in this situation, please look at doing an out-of-hospital DNR. Now, it does have to be countersigned by the physician. And oh, by the way, tattooing on your chest, "Do not resuscitate," doesn't work. I haven't thought of that. I have some friends, though, who were threatening to do that. You know, the kinds of people I worked with, you become a little jaded after a while. And part of it is the macabre sense of humor is to keep yourself from losing your mind. And that one, I always recommend keep it with individuals. So, true story, my mother-in-law died this spring at the age of 108. And until about a year and a half ago, she was in really amazing shape. She still played Rummy Cube every night, if you know that game. It's pretty intense as far as mind power. But she kept her out-of-hospital DNR in a jar in the refrigerator. Never could figure out why, but I recommend the families that you put it by the light switch so that when EMS comes in, they hit the light switch and they'll also find the out-of-hospital DNR. So I promised you I'd talk a little bit about what happens when all this doesn't work. So how do you set goals with families? I can tell you, I have sat in hundreds of family meetings, and 95% of doctors will start with, well, your mom has this and this and this. What do you want us to do? Not helpful, right? What's the logical answer? We want you to fix her. And then we're asking families to practice medicine. And people who practice medicine spend a really long time learning how to do it. They may not have it perfected, but they're better than you and I are. So we have to start out asking about the person. Tell me about your mom. Tell me about your dad. What has given their life joy? What has given it meaning? And I'm still working on, I teach, one of my jobs is I teach medical students a couple of times a year at UTMB. I've had students tell me, these youngsters, 20-somethings, and not to degrade young people, but they would say, well, you just got to get to the crux of it. No, please ask them about their person. Because what you do then is you establish some trust. You're signaling that you care about their mom, dad, cousin, brother, sister, aunt, uncle, whoever. And then you can say what has been important to them, what have been their goals, what have they told you about what was important to them, getting back to that life goals, fitting in with your medical goals. And then confirm your understanding. Basic empathic listening, right? Y'all learn that in school. Chaplains learn it. Doctors, not so much. So in negotiating goals, and I do teach this to nurses and social workers in the hospital setting, we're providing emotional support, right? I can see this is hard for you. These are really difficult decisions to make. It's hard to talk about this stuff. The basic acknowledgement that what we're doing is important, but it's difficult. And then use language that people can understand. Instead of saying, we're going to use CPR to do blah, 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 we are going to have, if your mom's heart stops, we're going to have to compress her chest. And we are going to have to give her special medicines. And here's what can happen. May also be that, particularly when you're talking ahead of time, you don't know everything you need to know. So you can make decision points and say, well, if this continues for another 2 months, then we will have to decide X, Y, and Z. In the ICU, it may be 2 days or 2 hours. You know, the time frames are different. But you can talk about short-term goals versus long-term goals versus different treatment options, and you can prioritize them, and you can say, we're going to try this, and if this doesn't work, we're going to do this. Because at the end of the day, we have to respect what's important to the person. And for everyone in this room, it's probably different. I've had experiences in the ICU that I've gone home and told my husband and daughter and son, if you do this stuff to me, I'm going to come back and haunt you. And I said that to a group the other week, and one of the guys looked up and he said, I think you'd come back and haunt him anyway. I thought that was mean, but it's probably true. So we have to plan treatments, and we have to recommend things that match with what's important to the person, with what the medical realities are. And we have to continue to educate and use words that people can understand, because I can guarantee you from my research and from my experience in the ICU, people don't know what those words mean. And it's okay to say, if you're witnessing a doctor or a nurse telling somebody something in fancy language, I'm wondering if you could break that down. Or say to the person, can you tell me what they just told you? The basic mirror back technique? Because that's how you find out. People don't want to sound stupid by saying, I don't understand what you just told me, start over. So we, as the practitioners on the soft side of things, chaplains, social workers, therapists, nurses even, we have to be the ones to encourage people, to empower people to advocate for themselves and for their loved ones. So, the important thing, help people advocate, articulate, encourage your family members. We're coming up on the holidays. You don't have to be a fun buster by asking people, have they thought about their death? But that is a time. I just wrote a little thing for a newsletter here where I encourage you, pay attention to what's going on with your family members. Watch them. Are they as sharp as they were? Are they remembering their recipes? Did they remember how a simple thing like how to set the table? Because some of these things are hints that things aren't as good as you thought they were. And help your family members to think ahead, or just start talking. Gee, Grandma, you've lived a really long life. What has been the best thing? Basic storytelling. And out of that, you'll get all kinds of stuff about what's been important, what has given them joy, what has frustrated them, maybe even some disappointments. But you'll get the kind of narrative that you need for when they're no longer able to speak for themselves. So here are a bunch of tools, and I'll stand out of the way so everybody can take a picture. The Caring Conversation Guide is done by a group out of, Caring Conversation Guide is done by the University of Kansas Center for Practical Bioethics. And it's a lovely little booklet that you can print off. It has the directives for Kansas in the booklet. Ignore that. But the really helpful thing about the booklet is it has very specific questions to talk to your family members or your clients about. And it's just a guideline, but it's helpful because people don't know necessarily what questions to ask. The advanced directives forms are on the Health and Human Services website. Respecting Choices and mydirectives.com. Respecting Choices was done out of Wisconsin. They charge a lot of money for their program, so it's a really good one, and they have trained facilitators. I've been trained in one of their first level of teaching. Really good stuff, but if any of you work for Memorial Hermann, they were going to adopt it and push it out citywide and countywide, but I don't know what's happening with that project right now. The Serious Illness Conversation Guide is a really nifty tool. It was devised by a group out of Boston. Atul Gawande, author of Being Mortal. Have any of you read Being Mortal? Everybody should read Being Mortal. It's a very easy read. Atul Gawande is a physician, surgeon, and oncologist, and he wanted to know more about how to deal with his patients who are coming to the end of their lives, right? You would think as an oncologist it would be part of basic training, but it wasn't. And so he went to people that he thought were pretty good at this. And so he talked to them, and he wrote the book, Being Mortal. The cool thing about the book is he does integrate some of his familial experiences, but he has several chapters in it on advanced care or senior living facilities and what makes a good one and what makes a bad one. Because his opening premise in the opening chapter is, well, there are two. One is I learned a lot of things in medical school, but dying wasn't one of them. And the other thing is that he said he didn't see us as a society embracing aging in the same way that we had in the past. Because what's happened is we scatter, right? My dad was living in Tennessee, and I live in Texas. I have a brother that lives in Maine and a brother that lives in Washington. Makes it really hard, right? So we don't have the same capacity in many cases of just bringing the person into our homes. The neat thing is, as a professional in the helping professions, you can sign on to their website and get access to all of their materials for free. But the Serious Illness Conversation Guide was devised for primary care physicians to have conversations with their patients after they had had a major health event but recovered. So talks to them about, okay, you were just in the hospital. What was that like for you? And fundamentally, what do you want to do if this happens to you again? But at the primary care physician, and we know the problem, right? My dad had had the same primary care physician for over 20 years, but that wasn't the guy he saw when he went in the hospital. He would see the hospitalist. So it's a conversation to be had at the very basic level of care on what's important to the person. And they're pushing this out nationwide. The Conversation Project is out of the University of Washington, a guy named Volandes, Dr. Volandes, and he's done some really interesting work with making videotapes of different kinds of health events, like CPR, and like what happens in advanced stages of congestive heart failure. The problem is he charges. So you know, and they're making some money off of that. So, but just know it's a resource, and if you're affiliated with a clinic or a group, it's a really good way to train some people. Here's some bibliographical stuff. The one I used most with the questions was the Johnson, Sigler, and Winslade book, Clinical Ethics, A Practical Approach. They're now in the 8th or 9th edition. But it's a very easy read. The cool thing is they have a lot of cases in there, so you can get some examples of what they're talking about.